It is really a pleasure to be with you all today. And for those of you who don't know AWHONN, I just thought I'd at least give you a little bit of background that AWHONN is the standard bearer organization for, and this is a calculated number, for 350,000 women's health, obstetric, and neonatal nurses in the United States. We advocate for key healthcare and nursing professional issues. We're a pioneer in developing and disseminating evidence-based nursing practice resources, and we're an international nursing leader. Today I'm just going to go over some of the importance of measuring and tracking perinatal RN staffing, describe what is known about the current trends in perinatal RN staffing, and discuss the need for more perinatal RN staffing research. This adorable little boy is my youngest grandson. He has obviously unruly hair like his grandmother, but he reminds me, and it's an important thing to remind us all, that the goal is to ensure that all women and newborns have equal access to evidence-based, high-quality nursing care, especially since a large part of the workforce are nurses. You know, my own family, I care very much about where they get the care they get, and I don't want to have to worry about where they're going and whether that care is evidence-based or not. So my work is personally motivated as well as professionally motivated. In the United States, and I think these numbers might be a little bit surprising to people not familiar with where women give birth in the United States, but about 79% of women give birth, about 79% of the hospitals in the United States have less than 2,000 births a year. And 47.4% of births occur at 500 hospitals where there are at least 2,475 infants are born each year. This means that not every hospital in the United States has an academic center, has in-house OB, in-house obstetricians, in-house anesthesiologists, and I have worked in multiple types of setting as a nurse. And I know the difference of standing in that unit by myself with only other nurses around and no other physicians in-house. Also, the care that happens in a perinatal unit includes multiple types of care: emergency triage and evaluation, medical surgical patients, unfortunately more so than ever before, operating room post-anesthesia units, intensive care, and indeed psychiatric care that can be very, very labor intensive. With this in mind, AWHONN has the perspective that we want every woman, regardless of where they receive their care, to have the same level of care. So if they are in a hospital, that the emergency room standards of nursing care would apply to them even if they were in an obstetric unit. And that doesn't exist today. So we did put out some staffing guidelines, and this has not been without controversy, but we updated these guidelines from 1983. The reason we felt the need to update these is because much has changed. Just looking at surgery alone, and cesareans, we all know, are major surgery. They do require much more nursing care than other types of non-surgical births. We've had a 100% increase since the last time AWHONN had staffing guidelines. We've had worse outcomes. You'd hope if we did many more interventions that we would have better outcomes, but we actually have worse outcomes. We've seen a 75% increase in severe maternal morbidity. That requires more nursing intensive care. A 184% increase in the number of women receiving blood transfusion during a hospital birth admission. Increases in the postpartum hemorrhage are associated with the overuse of labor induction. This is not a small number of morbidity affecting women in the United States. And for every induction that we do, that requires more nursing staff. In addition, these two graphics show their flow charts. They show you on the left for the green, or I guess anyway, the green one, um, the non-pregnant patient. This is a typical non-pregnant patient, how their electronic medical record will flow through the system. Compare it to a pregnant woman, and this is not a complex pregnant woman. This is a pregnant woman with only one baby. It's a much more complicated flow of records. And so right now, with the integration of an electronic health record, theoretically, they're supposed to save time of a nurse, but practically speaking, they are increasing a lot of time. And in addition, the flow of information from an outpatient to inpatient has to be much faster than a med-surg patient. A woman may come into the hospital in the evening, need an evaluation, and need to have her records available to the clinical team the next day for outpatient testing. And when those systems, which they are not currently when they're not integrated, then that causes slowdown and difficulties in the team being able to provide evidence-based care. There's over more than a decade, more like 2 decades worth of studies that link RN staffing and RN competencies to improving outcomes. These are 2 that I'll highlight here. The blue are the outcomes that have been shown related to RN staffing that I think are most relevant to a perinatal population. Unfortunately, there's been very limited curiosity in the effect of nursing staffing on birth settings and birth outcomes. It's mind-boggling how little curiosity there has been in that area. There has been some research done on the impact of nursing staff ratios on survival and outcomes for low birth weight infant and preterm infants. And I will call your attention to a recurrent theme in nurse research in the studies around nursing care that show that the qualifications of the nurse are associated with risk-adjusted mortality rates. And that's a consistent theme throughout all types of nursing staff research. Needleman, who had published the earlier study when he was at Harvard, then recently published this study in New England Journal of Medicine. And I think for the conversation today that we've been having around care transitions, this study finding I think is very appropriate to highlight. Higher than typical rates of patient admissions, discharges, and transfers during a shift were associated with increased mortality and an indication of the important time and attention needed by RNs to ensure effective coordination of care for patients at critical transition periods. I know, I've actually witnessed it myself, that when women are coming in from a home birth, that those transitions do not go smoothly as they should. And I think there's a very important role for understanding those transitions and making them more effective, in addition to the transitions within a hospital setting. So measuring the nursing care quality is also a very prime importance of A1, and one of the things we're looking at is to be able to understand and study the effect of nurse staffing on nurse-sensitive process and outcomes. And we also are working on developing nursing care quality measures. Our perspective is that the core or essence of nursing's work is caring relationships, specifically human interactions grounded in clinical caring processes. Nurses perform both collaborative and independent care. And during that physical work and being with and knowing the patients we care for can make a major difference in outcomes is our perspective. These data, the research I've pointed out to and others suggest that there would be similar kinds of outcomes in perinatal populations. Women in labor require frequent monitoring of both the woman and her fetus and rapid response to emergencies to avoid failure to rescue. Cesareans are major surgery. We cannot understaff those units when we have 30 to 60% C-section rates. Oxytocin and magnesium sulfate are high alert medications. Other countries have found that in order to improve outcomes, they needed to increase the surveillance and response to early warning signs. And we need to pay attention to the surveillance and the team mobilization that needs to occur in our teams as well. A1 has an organizing framework that in which to, because none of this comes without thinking about costs. And our organizing framework is when calculating staffing costs, we need to look at patient factors, nurse factors, and system factors. And that's how we should decide how many full-time equivalents are needed as far as nurses or others. This also, in assessing whether the staffing costs were effective and efficient, we need to look at patient outcomes, actual nurse staffing, and system issues and events. Maternity nurses are essential frontline clinicians. They are in the hospitals 24 hours a day, 7 days a week. Not everyone else on the care team are in the hospitals 24 hours, 7 days a week. And they're important for mobilizing the team response. Now, birthing centers have various types of staffing models: RNs, LPNs, nurses, aides. And right now, our guidelines cover the situation of care that the woman needs, not necessarily the setting. So our guidelines are applicable to all settings. Home births, where this typically from what, and this is, it's hard to find these data, but from my experience, usually do not have an RN take care of them during pregnancy, during birth, or postpartum. We're not sure whether women giving birth in non-birth setting, in a non-hospital birth setting by non-RNs, are missing important nursing interventions. There's community-based models of care since the 1980s. The nurse-family partnership programs have had some randomized controlled trials that have shown that there's an improvement in maternal life course. These community-based models have shown an improvement in decreasing perinatal cigarette smoking, fewer hypertensive disorders of pregnancy, and improved spacing of children. So with that background, A1, understanding the limitations of the data, we formed a data collaborative. This was something we could do to try to understand perinatal staffing in the United States. Our data collaborative consists of 179 hospitals, about 413,000 births a year, and 23,000 nurses work at those hospitals. This is like other collaboratives where people pay to participate, and it's not a generalizable sample, but it is the largest database we have to date that tells us details around staffing patterns. This shows you by birth category, hospitals by birth category or volume of birth. The turquoise are the % of hospitals in the data collaborative within that birth volume of hospitals. We broke our collaborative group into 5 different groupings based on birth volume. We looked at 32 different staffing guidelines, and A1's guidelines, when we talk about staff guidelines, there's 32 different types of care situations that our guidelines encompass. This is, I'm only showing you today the interpartum just to show you the complexity of measuring nurse staffing. It's not a simple question to answer, but in this case, we ask every single hospital for 32 different kinds of situations. This is the interpartum data answering the question, is your hospital meeting the A1 guidelines for interpartum RN staffing? As you can see, oxytocin and women without pain management, and that would be regional analgesia, they were most likely not to meet the A1 staffing guidelines. So we don't know what meaning to bring to that other than it does cause us concern. Orientation hours by nursing experience also was, as we would expect, the more experienced the nurse, the more orientation hours they are getting from among the data collaborative hospitals. But it is pretty interesting to note that the hours range from 216 hours of orientation to 1,872. So there's inconsistency once somebody's hired, how much time they will be given orienting to this area. When you look at the number of direct care RNs per 1,000 births, and we broke it down, as you can see, by the colors represent different groupings of hospitals based on the number of births per hospital. And we found that there's quite a wide variation of the number of nurses per 1,000 births. And it ranged from 6.6 to 82. You can see those outliers, but most of them fell pretty consistent in the same, around the same range, but there was some pretty wide variation among the group. Now, studies have shown the better educated the nurses are, the better the outcomes. In particular, the percent of nurses that have a bachelor's degree or higher has been shown to improve outcomes. We asked how many of the nurses in their sample had a bachelor's degree, and there was hospital was 0% to 92%. Now, I would, we need to understand more how the level of education will affect outcomes. So the summary of my key points are that nurse staffing, nurses' competence, and nurses' education have been shown to affect patient outcomes. The number of interventions performed and patient population characteristics also affect nurse staffing. And there is limited data on the types of perinatal nurse staffing in the United States. We would like to apply the recommendations. I would like to highlight our recommendations that are not new to the IOM. These are recommendations from their study, The Future of Nursing, Leading Change and Advancing Health. Key point number 1 is that nurses should practice to the full extent of their education and training. Key point number 2 is that nurses should achieve higher levels of education and training through an improved education system that promotes seamless academic progression. So clearly we need to encourage and support more BSNs in the labor and delivery setting in perinatal nursing. Key point number 3, nurses should be full partners with physicians and other health professionals in redesigning healthcare in the United States. I think this is important to note. In 1982, nurses didn't even really make it to the report. We are now on several committees, but don't typically have the same number of nurses, though there are more nurses in the United States than physicians, but usually there might be a token nurse on that committee. And rarely are we in a leadership position if we're on those committees. And point number 4 is effective workforce planning and policy making require better data collection and improved information infrastructure. And that's a theme we've heard throughout the day. And I would say in particular looking at failure to rescue, severe maternal morbidity, labor support, breastfeeding support, transitions of care, and transport. So 2 key points. It's important to measure and track perinatal staffing patterns. And it's also, we need more perinatal nursing staffing research for various types of birth settings. So thank you very much.
Our discussant for this session will be Susan Stapleton, who is a doctor of nursing practice and also a certified nurse midwife. She's the founder of the Reading Birth and Women's Center in Reading, Pennsylvania, and is the director president of the Commission for the Accreditation of Birth Centers. So, please.